Welcome back to the deep dive. Okay, today we're really strapping in
We are indeed.
because we're tackling, I think, maybe the most intense, rapid physiological shift anyone ever goes through.
Absolutely. The uncomplicated newborn's transition, it's profound.
Yeah, those first 28 days, but especially like the first few hours, it's the ultimate biological startup sequence, isn't it?
That's a great way to put it. And for anyone studying this, maybe looking at CNUR 303 materials, the real trick isn't just knowing the facts.
Right.
It's seeing how they all link together, how one change triggers the next super fast.
So our mission today,
Mm.
translate all that dense physiology.
Exactly. Make it immediately usable. We're focusing on two things, really. First, what are nurses, the extra caregivers, actually watching for minute
Yeah.
by minute? What are those critical assessment points?
Okay, and second,
So second, what do new parents absolutely need to know before they go home? That essential, empowering education piece.
so it's like the cheat sheet for the newborn machine. You mentioned the first 28 days is the official period.
That's the neonatal period, yes. But the real drama, the major adaptations for surviving outside the womb, they happen incredibly fast, mostly in the first 6 to 8 hours.
6 to 8 hours. Wow.
It's an incredibly dynamic time frame, and we can kind of organize it around 6 main jobs the baby has to nail.
6 core tasks. Let's hear them.
Okay. Number 1, and maybe the most obvious, establishing and keeping up respiration, breathing.
Makes sense.
Second, adjusting circulation, a total plumbing overhaul. Third, regulating their temperature all on their own. Fourth, taking in food, holding it down, digesting it.
Ingesting nutrients, check.
Fifth, getting rid of waste, peeing and pooping.
The essentials.
And finally, number 6, regulating their weight and their whole metabolic state. If they manage those 6 things, they're generally stable.
Okay, 6 key tasks. That helps frame it. So let's start right at the beginning, like seconds after birth. You said they don't just stabilize instantly, right? There's a pattern.
Yes, a really predictable behavioral curve. It was described way back by Desmond and colleagues. Think of it like a 3-act play the baby goes through.
A 3-act play.
Yeah.
Okay, Act 1. What happens right away?
Act 1 is the first period of reactivity. It's short, maybe birth to about 30 minutes old, and it is intense.
Intense how?
Physiologically, the heart rate just rockets up to 160, maybe even 180 beats per minute. Then it starts to drop after that half hour. Respirations are fast too, 60 to 80 breaths a minute, and kind of irregular.
Sounds like chaos, but good chaos.
Organized chaos, exactly. Because behaviorally, the baby is wide awake, super alert, making spontaneous movements. This is that golden window for initial bonding.
And for that first feed.
Absolutely critical for the first feed attempt. Their sucking reflex is strongest. We also often see the first meconium stool passed here.
Which tells us the gut's working.
Right. It's all systems go. That alertness is almost like an evolutionary push to find the breast, to connect.
But they can't sustain that intensity.
Right. No way. It burns too much energy. So that leads us into Act 2, the period of decreased responsiveness.
Okay, so this is the crash, the quiet time.
Pretty much. It usually lasts about 2 to 3 hours after birth. Everything kind of settles down.
Like heart rate.
Heart rate comes into the normal newborn range, 110 to 160. Breathing slows down, 40 to 60 breaths a minute. It might be shallow, but it's regular.
And behaviorally, less interested.
Much less interested in anything external. They're sleepy. And this is a key point for nurses and parents. If you missed that first 30-minute window for feeding,
Gonna be tough now.
it can be really hard to wake them up enough to feed effectively during this phase. It really highlights why timing is everything for those early interventions. You got to grab that first opportunity.
Okay, so first reactivity, then the quiet phase. Then what? Act 3.
Then the baby kind of reboots. Act 3 is the second period of reactivity. Usually happens somewhere between 2 and 8 hours after birth.
They wake up again.
Yep, become alert again. Sometimes quite intensely. You might notice more mucus production. They might seem a bit gurgly or congested as they cleave out remaining lung fluid.
And the gut wakes up again, too.
Peristalsis definitely increases. Often see more meconium passed. And for parent education, this is huge. We tell parents, look, if that first feed didn't go well or you missed it, this is another fantastic chance.
The second golden window.
Exactly. A renewed opportunity to work on latching, to establish feeding before they settle into more regular sleep-wake cycles.
Okay, that reactivity pattern makes sense. Now let's get into the absolute core of it all. Breathing. That switch from water to air. You said 4 triggers.
Four main things happen almost simultaneously to force those lungs open. It's not just one magic button.
Right. What's trigger number one?
The big one is chemical factors. The instant that umbilical cord is clamped, the oxygen supply from the placenta just stops.
Cut off.
Totally cut off. So the baby's blood oxygen level plummets and carbon dioxide levels shoot up. This makes the blood acidic.
Like an internal alarm bell.
Precisely. Chemoreceptors pick up that pH change, that acidity, and send an urgent message straight to the respiratory center in the brainstem, the medulla.
And the medulla says,
Breathe, now. It overrides everything else and triggers that first strong gasp, that first muscle contraction to pull air in.
wow. Okay, chemical trigger. What's next?
Next up are the mechanical factors. This is where a vaginal birth really gives a mechanical advantage. As the baby squeezes through the birth canal,
The chest gets compressed.
exactly, like squeezing a sponge, about a third of the fluid in the lungs gets pushed out.
And then?
The moment the chest emerges, that pressure is released. The chest wall recoils, expands, and that creates negative pressure inside the chest like a vacuum,
Pulling air in.
pulling that first breath of air in. And then when the baby cries, which they usually do, that crying helps push the air deeper, opening up all the little air sacs, the alveoli.
That mechanical squeeze is so important. What happens if they don't get it? Like in a C-section before labor.
That's a really key connection. If they bypass that squeeze, they tend to retain more fluid in their lungs. And that's often why we see transient tachypnea of the newborn, or TTNB.
TTNB, rapid breathing.
Yeah, rapid, sometimes shallow breathing. The respiratory rate can go up to 100, even more sometimes. It's because the lungs are still a bit waterlogged.
So it's mild respiratory distress.
Usually mild, yes.
Mhm.
It typically resolves on its own within 24 to 48 hours as the lungs absorb that fluid.
Yeah.
But it often means the baby needs observation, maybe a bit of oxygen. The mechanical trigger didn't fully happen.
Okay. Chemical, mechanical. What's trigger number three?
Thermal factors, the temperature shock.
From warm room to cool room.
Exactly. Going from a cozy 37 degrees Celsius in the uterus to a room that's, maybe 22, 24 degrees, that sudden cold hits the skin receptor.
Another signal to the brain.
Another jolt to the respiratory center. Breathe.
Right.
We actually use this sometimes. A quick cold stimulus can help get a sluggish baby going. But you have to be super careful because prolonged cold is dangerous. They burn through their energy stores way too fast trying to stay warm. It's a fine balance.
Right. And the last trigger, number four.
Sensory factors. Just the sheer overload of new sensations.
Like what?
Being touched, rubbed vigorously during drying, hearing voices, sounds, seeing bright lights for the first time, all that sensory input bombards the central nervous system,
Wakes everything up.
wakes it up, and helps initiate and maintain those rhythmic breathing movements. So drying the baby isn't just about warmth, it's crucial sensory stimulation to kickstart breathing.
Four triggers working together.
Okay.
So breathing has started. How do we know if it's good breathing? What's normal versus distress?
Okay, normal newborn breathing looks a little different, and sometimes it worries parents. First, they are obligatory nose breathers, meaning
Mhm.
if their nose gets blocked, say with mucus, they really struggle to breathe through their mouth. So keeping the nose clear is important.
Okay. What else is normal?
Abdominal breathing is totally characteristic. You'll see their belly rise and fall quite dramatically with each breath. That's normal, not a sign of distress.
And those scary pauses parents sometimes see.
Ah, yes, periodic breathing. This is really common and normal in the first few days. They might have these short pauses, maybe 5 to 15 seconds long.
15 seconds feels like forever.
It does, but the key is, during these pauses, there's absolutely no change in the baby's heart rate or their color. They don't turn blue, then they just start breathing again normally.
So it's just immature control.
Exactly. Immature respiratory control center. We teach parents. The pause itself isn't the emergency. It's an emergency if they stop breathing and change color or get limp.
Got it. Now, the red flags, the real signs of respiratory distress. What are nurses watching for, and what do parents need to recognize?
There are three main visual signs. First, nasal flaring. You see the nostrils widening with each breath in.
Why do they do that?
They're trying to decrease airway resistance, trying to pull in more air. Second sign,
Retraction?
that's when you see the skin getting sucked in, either between the ribs, that's intercostal, or below the ribcage subcostal. It means they're using accessory muscles, working really hard to create enough negative pressure to breathe.
Okay, flaring, retractions, and the third sign is often a sound.
Yes, grunting. This is maybe the most specific sign of significant distress. It's a sound they make when they breathe out.
What does it sound like?
kind of like a little sigh or a short moan with each exhale. What they're doing is partially closing their glottis, their vocal cords,
Why?
to trap air in the lungs, basically, to create back pressure called PEEP, positive end expiratory pressure. It helps keep the tiny air sacs, the alveoli, from collapsing. It's a sign they are fighting to keep their lungs open.
So flaring, retractions, grunting. Those are the big three visual audible signs. What about the numbers, the rate?
The rate is crucial. Normal is 30 to 60 breaths per minute. Anything consistently below 30 or above 60 is a major concern and needs assessment.
And color. We always think of blue.
Central cyanosis, blue lips, blue tongue, blue mucous membranes is a very serious sign, but it's often a late sign.
Late. I mean, the problem's been going on a while.
Yes. By the time they're centrally cyanotic, they are significantly lacking oxygen. We want to intervene before that happens. We also watch for apnea, which is a pause in breathing that lasts longer than 20 seconds. That's severe distress.
So the message for parents is,
If you see nasal flaring, if you see retractions, if you hear grunting, call for help immediately. Don't wait for the baby to look blue. Those are the early warnings. Okay, so breathing is established. The next huge hurdle is the circulatory system. It has to completely reroute itself, like instantly.
because fetal circulation is totally different, right? It relies on the placenta.
Completely. The placenta does the job of the lungs' gas exchange. So the fetal circulation is cleverly designed to bypass the lungs for the most part. It uses 3 special shortcuts, or shunts.
Let's break down those shunts. What are they and what do they do?
Okay, first is the foramen oval. It's basically a flap or a hole between the 2 upper chambers of the heart, the right and left atria.
What does it do?
In the fetus, pressure is higher on the right side of the heart. So this hole lets blood flow directly from the right atrium to the left atrium, skipping the trip to the lungs.
Smart. Okay. Shunt number 1. What's number 2?
The ductus arteriosus. This is a blood vessel that connects the pulmonary artery, which normally takes blood to the lungs, directly to the aorta, the main artery supplying the body.
Another lung bypass.
Exactly. It shunts blood away from the high-resistance fetal lungs directly into the systemic circulation.
And number 3.
The ductus venosus. This one bypasses the liver. It shunts oxygenated blood coming from the umbilical vein directly into the inferior vena cava, the large vein going to the heart.
So lungs and liver are mostly bypassed. Makes sense in the womb, but at birth, this whole system needs to shut down fast.
Instantly. The goal is to switch to the adult pattern. Right side pumps to the lungs, left side pumps to the body. And the key driver for this change is a massive pressure flip.
Pressure flip.
Yeah. Before birth, the fluid-filled lungs create high resistance to blood flow. That makes the right side of the heart the high-pressure side.
But when the baby takes that first breath,
The lungs fill with air, and suddenly the resistance in the pulmonary blood vessels plummets. Blood rushes into the lungs easily. This dramatically increases blood flow returning to the left side of the heart.
so the left side becomes the high pressure side.
Exactly. The pressure flips. Left side pressure becomes higher than the right side. And that pressure change is what slams the door shut on those shunts.
Oh, okay. We had that mnemonic, didn't we? Close. How did that map out the closures?
It works pretty well. C is for clamp cord. When you clamp the umbilical cord, blood flow through the umbilical vessel stops. This causes the ductus venosus, the liver bypass, to constrict and close functionally pretty much right away.
Okay. C, clamp cord, ductus venosus closes.
L is for lungs expand. As the lungs fill with air and blood flow to the left atrium increases, the pressure on the left side shoots up. This higher left atrial pressure pushes the flap of the foramen oval shut against the atrial wall.
Like closing a one-way door. How fast does that happen?
Functionally within minutes to hours. It seals permanently later, but the functional closure is quick.
Okay. C, LO.
O is for oxygen increase. As the baby breathes air, the oxygen levels in their blood rise significantly. This higher oxygen level is actually a signal for the muscle in the wall of the ductus arteriosus to constrict.
So oxygen closes the lung bypass vessel.
Yes, it causes it to clamp down hard. Functional closure usually happens within the first day or so. The S and E in close just remind us that systemic pressure rises and everything shifts to the adult circulation pattern.
It's amazing how coordinated that is. But you mentioned the ductus arteriosus closure takes a bit longer to become permanent. Is that why murmurs are common?
Exactly. The ductus arteriosus might take hours, days, or even weeks to fully close and turn into a ligament. During that time, a little bit of turbulent blood flow can still happen through it, creating a heart murmur.
So a murmur isn't automatically bad.
Not necessarily. Many newborn murmurs are transient and benign, just related to this closure process. But a nurse needs to listen carefully. Is it loud? Is it present all the time? And crucially, is it accompanied by any other symptoms?
Like what kind of symptoms?
Poor feeding, episodes of stopping breathing, apnea, persistent blueness, cyanosis, or looking very pale, pallor. A murmur plus other symptoms needs immediate investigation. An isolated soft murmur might just be watched.
Got it. So assessing circulation also means checking the heart rate very carefully.
Absolutely. Apical pulse, listen to for a full minute. Normal average is 110 to 160 beats per minute.
But it varies.
It does, can go up to 180 when they're crying hard and drop down to 85 or 100 when they're in a deep sleep. That's normal variability.
What's not normal?
Persistent tachycardia, a rate consistently over 160 when they're resting, could signal things like infection, dehydration, maybe pain.
And a low heart rate.
Persistent bradycardia under 100, especially under 80, is very concerning. It usually means significant hypoxia, lack of oxygen, or asphyxia. That's an emergency. We also watch skin color closely. Pallor, that pale look, could be anemia or poor circulation from cold stress or even sepsis.
Okay, this seems like a good place to talk about a key nursing practice. Delayed cord clamping, or DCC. Waiting before clamping the cord. Why is this now the standard?
Yeah, it's a really important shift in practice. DCC means waiting, usually 30 to 60 seconds, sometimes even longer, like 2 to 3 minutes, before clamping the umbilical cord, as long as the baby is stable.
Why wasn't this always done?
Historically, there was often a rush, maybe for convenience or some outdated concerns about giving the baby too much blood, but the evidence now is overwhelming.
Evidence for waiting.
Yes. At the moment of birth, a significant amount of the baby's blood volume, up to a third, maybe 80 to 100 milliliters, is still in the placenta and cord.
That's a lot for a tiny baby.
It's huge. Waiting allows that blood to transfer back to the baby. It's called placental transfusion.
What are the benefits of that extra blood?
Several big ones. First, that increased blood volume helps make the transition smoother, especially for the heart and lungs, better circulation from the start. Second, and this is really key long term, it significantly boosts the baby's iron stores.
Iron stores. Why is that so important?
Iron is critical for making hemoglobin, which carries oxygen. Babies are born with iron stores, but getting that extra boost from the placental blood helps prevent iron deficiency anemia later in infancy. Anemia can affect development.
So it sets them up better for the first few months.
Exactly. And research also shows potential benefits like reduced risk of bleeding in the brain, interventricular hemorrhage, especially for premature infants. So nurses are big advocates for DCC now, unless the baby needs immediate resuscitation.
All right, moving on. Temperature regulation. You mentioned newborns lose heat easily. Why is that?
They're just not built for efficiency yet. They have very thin subcutaneous fat, their blood vessels are really close to the skin surface, and they have a huge surface area compared to their weight. They're like little radiators.
So the goal is to keep them in a neutral thermal environment.
That's the technical term, yes. It means an environment where they use the least amount of energy possible to keep their core temperature stable, ideally between 36.6 and 37.2 degrees Celsius axillary.
And to do that, we have to fight the 4 ways they lose heat.
Exactly. Nurses are constantly intervening against these 4 mechanisms.
Let's break them down. First, convection.
Convection is heat loss to moving air, like a draft. The intervention is straightforward. Wrap the baby snugly, put a hat on their head right away, and make sure the room temperature is stable, usually around 22 to 26 degrees Celsius.
Okay. Next, radiation.
Radiation is heat loss to cooler objects nearby, but not touching. Think of a cold window pane or an outside wall.
Even if the air is warm.
Even if the air is warm, the baby radiates heat towards that colder surface. So the intervention is about placement. Keep cribs and warming tables away from cold walls and windows.
Got it. Third one, evaporation. You mentioned this is a big one right after birth.
Huge. Probably the most significant source of heat loss initially. It's simple physics. Liquid turning into vapor uses energy, and it pulls that energy, that heat, right out of the baby's skin.
So a wet baby is a cold baby. Fast.
Extremely fast. This is why drying the baby immediately and thoroughly after birth is non-negotiable. Every bit of amniotic fluid needs to come off. Same goes for after a bath. Get them dry and wrapped quickly. Change wet blankets.
Makes sense. And the last one, conduction.
Conduction is direct heat loss to a colder surface they're touching.
Like a cold scale or exam table.
Exactly. So interventions include putting a warm blanket or cover on the scale before weighing, pre-warming any surfaces they'll lie on, or the best method, skin-to-skin contact with a parent, it's fantastic. It minimizes both conductive and radiant heat loss, helps regulate the baby's temperature perfectly, plus all the bonding benefits. It's physiology and connection working together.
Okay, so we try to prevent heat loss, but if they do get cold, how do they make heat? They don't shiver right.
Not effectively, not until they're quite cold stressed. Their primary way to generate heat is called non-shivering thermogenesis, or NST.
Non-shivering, how does that work?
They metabolize a special type of fat called brown fat or brown adipose tissue, BAT. It's located mainly around their neck, shoulders, between the shoulder blades, and around the kidneys and adrenals.
Brown fat, why is it special?
It's packed with mitochondria and highly vascular. When the baby gets cold, hormones trigger the rapid breakdown of this brown fat, which generates a lot of heat very quickly.
Like an internal furnace.
Kind of, but it's a furnace with very limited fuel. And burning that fuel has significant costs.
What are the costs? What happens in cold stress?
Okay, so they start burning brown fat. This process requires a lot of oxygen, so the respiratory rate might increase, potentially leading to respiratory distress.
Okay, it uses oxygen. What else?
It burns glucose, a lot of glucose. Their limited blood sugar stores get used up very quickly trying to generate heat.
Leading to low blood sugar.
Exactly. Hypoglycemia. This is a major danger of cold stress. Low blood sugar can harm the brain. Cold stress also causes blood vessels in their skin to constrict to save heat.
Making them look pale or mottled.
Yes, pale, mottled skin. So cold stress is this dangerous cascade. Increased oxygen use, increased glucose use leading to hypoglycemia, and potential respiratory distress. Prevention is absolutely key, especially in preterm babies who have even less brown fat.
Okay, prevention is critical. Let's shift gears slightly to the other tasks. Elimination and metabolism. These are big topics for parent education before discharge. Let's start with peeing. What's normal?
The pattern is usually pretty predictable and reassuring for parents once they know it. They might pee right at delivery, but the general rule is simple. The number of wet diapers should roughly match the baby's age in days for the first week.
So, 1 wet diaper on day 1, 2 on day 2.
Exactly, up until about day 6 or 7, when they should settle into having 6 to 8 good wet diapers every 24 hours. It's an easy way for parents to track hydration.
What about that pinkish or reddish stain parents sometimes freak out about? Is it blood?
Almost always no. It's usually uric acid crystals. They look pink or orange-red, kind of like brick dust in the diaper.
Why do they happen?
It's common in the first few days when the urine is very concentrated, especially before the milk supply is fully established. It's normal, it's transient, and it's really important nurses tell parents about it proactively so they don't panic thinking it's blood.
Good tip. Okay, what about the other end? Stool patterns.
The first stool is meconium, that thick, sticky, tarry, black, or dark green stuff. Passing meconium, ideally within the first 24 hours, is a key sign that the gut is open and working.
Then it changes.
Yes, it transitions. From meconium, it becomes looser and greener, that's transitional stool. Then, depending on feeding, it changes again. Breastfed babies typically have yellow, seedy, looser stools. Formula-fed babies tend to have paler, more formed stools.
And this reflects the gut maturing.
Yes, and importantly, the gut getting colonized by bacteria. Those gut bacteria are essential, partly because they eventually start producing vitamin K, which newborns lack at birth.
We'll come back to vitamin K. What about spitting up? Seems like every baby does it.
It is incredibly common. Gastroesophageal reflux, or GER, happens in a lot of babies, maybe up to 70%, especially in the first 3 months.
Why so common?
The little muscle at the bottom of the esophagus, the lower esophageal sphincter, is just immature. It relaxes when it shouldn't sometimes, letting stomach contents come back up.
So, mostly normal.
For most babies, yes, a bit of spitting up is normal laundry problem, not a medical one. We teach parents it's usually okay and give tips like avoiding overfeeding, burping frequently during and after feeds, and maybe keeping the baby upright or head slightly elevated for a bit after eating.
Okay, and finally the liver. It takes over jobs from the placenta, right?
Yeah.
What are its main newborn tasks?
It's a powerhouse. It has to start managing glucose storage and release, storing iron transferred from the mother, producing coagulation factors to help blood clot, and the really big one is handling bilirubin.
Bilirubin, that's linked to jaundice.
Exactly. Bilirubin is a yellow pigment, a waste product from the normal breakdown of red blood cells. Before birth, the placenta cleared it. Now the baby's liver has to do it.
How does it do that?
It has to take the bilirubin, which is fat-soluble and toxic in that form, unconjugated, and convert it, or conjugate it, into a water-soluble form. Only the conjugated form can be easily excreted in bile, then into the stool and urine.
What if the liver isn't quite ready for that job, like in a premature baby?
That's the issue. If the liver is immature, or if there's a delay in processing conjugation, or if the baby isn't feeding and pooping well to get rid of it, that unconjugated bilirubin builds up in the blood.
And causes the yellow skin and eyes jaundice.
Precisely. That's the basis of physiologic jaundice, and why things like prematurity or feeding problems increase the risk of jaundice becoming problematic.
Okay, let's talk about the standardized ways we assess newborns. Everyone knows the APGA score. What's its real purpose?
The APGA score appearance, pulse, grimace, activity, respiration is done at 1 minute and 5 minutes after birth. Its purpose is very specific and very important. It assesses the baby's immediate transition to life outside the uterus.
So how well are they adapting right now?
Exactly. And crucially, does this baby need help? Does this baby need resuscitation?
What does it not tell us?
This is critical. The APGA score does not predict long-term neurological outcome or future health. A low score at 1 minute might just mean the baby needed a little help getting started. A good score at 5 minutes is reassuring about the immediate transition. It's a snapshot, not a crystal ball.
Okay, so a score of 7 to 10 is good routine care. What if it's lower?
If the 5-minute score is less than 7, the assessment is repeated every 5 minutes up to 20 minutes until the score is 7 or higher, or until resuscitation efforts dictate otherwise. A score of 0 to 3 indicates severe distress requiring immediate full resuscitation.
And routine care starts if the baby meets certain criteria.
Yes. If the baby is term gestation, is crying or breathing well, and has good muscle tone, we can proceed with routine care, which often starts with skin-to-skin contact, drying, and just assessing the heart rate.
What are the standard vital signs that get checked repeatedly?
We monitor heart rate apical pulse for a full minute, looking for that 110-160 range. Respiratory rate, watching the rise and fall of the chest or abdomen for a full minute, aiming for 30-60 breaths per minute, and checking for those distress signs we talked about.
Flaring, retracting, grunting.
Right. And temperature usually taken under the arm, axillary route, aiming for that 36.6 to 37.2 C range. These are the cornerstones of monitoring their stability.
Okay. Measurements. Average weight is roughly 2,500 to 4,000 grams, or about 5.5 to 8.8 pounds. But the weight loss after birth that causes so much anxiety.
Oh, absolutely. This is probably one of the most important pieces of anticipatory guidance nurses provide. We have to normalize expected weight loss.
How much is normal?
It's normal for newborns to lose up to 10% of their birth weight in the first few days, maybe 5–7% for breastfed babies, slightly less for formula-fed sometimes, but up to 10% is considered within normal limits.
Why do they lose weight?
It's mostly fluid shifts. They're born quite juicy, and they lose some of that extracellular fluid. Plus, they pass meconium, and their initial calorie intake from colostrum or formula is small while they're learning to feed effectively.
So when a parent sees their 8-pound baby drop down to, say, 7.5 pounds, they shouldn't automatically panic.
Exactly. We need to reassure them this is expected physiology. The key milestones are they should stop losing weight by around day 5, and they should be back up to their birth weight by day 10 to 14.
And if the loss is more than 10%, or they aren't regaining?
Then we investigate. Is there a feeding problem? Is the milk supply adequate? Is the baby latching well? Is there dehydration? Or could there be an underlying illness? More than 10% loss triggers a closer look.
We also categorize babies by weight relative to their gestational age, right? SGA, LGA, AGA.
Yes. Small for gestational age, SGA, is below the 10th percentile for weight. Large for gestational age, LGA, is above the 90th percentile. And appropriate for gestational age, LGA, is between the 10th and 90th.
Why are these categories important?
They help us anticipate risks. An SGA baby might be more prone to low blood sugar or problems staying warm. An LGA baby, often born to a diabetic mother, is also at risk for hypoglycemia and potentially birth trauma if they were large. It helps tailor our initial assessments and monitoring. Community nurses will later plot these on growth charts. So, after the initial checks and stabilization, there's a more detailed head-to-toe physical exam. Ideally, this happens around maybe 6 hours of age.
Why then?
The baby has usually gone through that first period of reactivity and the subsequent quiet period. They might be entering the second period of reactivity, but things have settled a bit. It's also a great time to do it with the parents present.
For teaching opportunities.
Exactly. You can point things out, explain normal variations, address their concerns directly while you're doing the assessment.
Let's focus on the head assessment. This is where parents often see things that look worrying but might be totally normal, like swelling.
Yeah.
How do we tell the difference between common swelling and something serious?
Okay, this is a classic nursing distinction. First, you might see molding. That's just the temporary reshaping of the head bones as they overlap to fit through the birth canal. Makes the head look a bit cone-shaped. Totally normal, resolves in a few days.
Okay, molding is just shape. What about actual swelling? Caput succedaneum.
Kaput is soft, puffy swelling like edema in the scalp tissue. The key identifier is that it crosses the suture lines. It feels boggy and covers a wider area, maybe the whole top of the head where the pressure was.
Is it serious?
No, it's very common, especially after a long labor or vacuum delivery. It's just bruising and fluid, resolves on its own in about 3 to 4 days. Looks dramatic, but it's benign.
Okay, caput crosses suture lines, resolves quickly. What about cephalohematoma?
This one is different. It's a collection of blood under the periosteum, that tough membrane covering the skull bones. Because it's under that membrane, it does not cross suture lines.
So it's confined to one bone, like a lump.
Exactly. It feels firmer, like a well-defined bump on one specific cranial bone. It's caused by trauma during birth, maybe forceps or vacuum, causing small blood vessels to rupture.
Does it resolve quickly?
No, this one takes much longer. It might actually get bigger for a couple of days, then slowly resolves over 3 to 6 weeks.
Weeks. And does it have other risks?
Yes. Because it's trapped blood, as that blood breaks down, it releases bilirubin. So babies with cephalahematomas have a significantly higher risk of developing jaundice that needs monitoring or treatment.
Okay, caput versus cephalohematoma, crosses sutures or not. Resolves fast or slow, risk of jaundice or not. Crucial difference. Now, what's the really dangerous one? The red flag.
The one we absolutely have to watch for, though thankfully rare, is subgale hemorrhage, SGH.
Subgale hemorrhage, what is that?
This is bleeding into the potential space between the scalp aponeurosis, a layer under the scalp, and the periosteum covering the skull. It's a large, loose space.
Why is that so dangerous?
Because that space can hold a massive amount of blood. The baby can essentially bleed out into their own scalp, leading to severe hypovolemic shock and potentially death if not caught early. It's strongly associated with difficult vacuum deliveries.
Wow. So how do nurses monitor for this?
Vigilance is key, especially if there were risk factors like a difficult vacuum birth. The protocol involves measuring the head circumference right after birth, then checking it again hourly for the first 3 hours, and then every 4 hours for the next 24 hours.
Looking for a rapid increase.
Exactly. A tense, boggy scalp that feels like it's spreading and a rapidly increasing head circumference are ominous signs demanding immediate medical intervention. Early detection saves lives here.
Okay, moving down from the head. Neurological status. What's normal posture and movement?
A healthy term newborn typically lies in a flexed position, arms and legs pulled in towards the body. Their movements should be generally symmetrical. Both arms move, both legs move.
What if movement is asymmetrical, like one arm isn't moving well?
That's a red flag for potential injury during birth. Could be nerve damage, like a brachial plexus injury affecting the shoulder and arm, or it could even be a fracture, most commonly of the clavicle, collarbone. Any asymmetry needs investigation.
We also check newborn reflexes. Why are these important, beyond just checking if they're present?
They tell us about the integrity of the central nervous system, but they're also practical tools, especially for feeding. The rooting reflex baby turns head towards a touch on the cheek, helps them find the nipple.
And the sucking reflex.
Obviously crucial for eating. The Moro reflex, or startle reflex, where they throw their arms out then bring them in when startled, shows neurological function. Palmar and plantar grasp. Babinski. They all give us information.
How should parents understand these reflexes?
We need to teach them how these reflexes help the baby. For example, with rooting, don't try to force the baby's head onto the breast. Just stroke the cheek or the mouth and let the baby turn and find it themselves. Working with the reflexes makes feeding easier and less frustrating.
Good point. Let's talk skin. We know acrocyanosis, blue hands and feet is okay for a bit. Central cyanosis is bad. What about jaundice timing?
The timing is everything for jaundice. Jaundice appearing after the first 24 hours of life is usually physiologic, the normal process of the liver getting up to speed. It needs monitoring, but it's generally expected.
But jaundice before 24 hours?
Jaundice in the first 24 hours is always considered pathologic or abnormal until proven otherwise. It suggests a faster rate of red blood cell breakdown or a serious liver issue. Needs immediate workup, could be blood type incompatibility, Rh or ABO, infection, or something else serious.
Okay, timing is key. What about other common skin findings that are totally benign, things nurses can reassure parents about?
Oh, lots of them. Vernix caseosa, that cheesy white coating, it's protective like natural moisturizer. Don't scrub it off
Good
vigorously.
to know. What else?
Lanugo, that fine downy hair, especially on the back and shoulders, normal, disappears over time. Milia, tiny white bumps, usually on the nose or chin, just blocked oil glands, they go away.
And that blotchy rash.
Erythema toxicum. Sounds scary, but it's super common. Looks like red blotches, sometimes with a little white or yellow dot in the middle. Comes and goes, moves around the body. Totally harmless, newborn rash.
What about birthmarks? Like Mongolian spots?
Mongolian spots are those bluish-gray, bruise-like patches, often on the lower back or buttocks. Very common, especially in babies with darker skin tones. Important to document them so they aren't mistaken for actual bruises later. They usually fade, but can persist.
And stork bites.
Also super common, maybe up to 80% of babies have them. They're those pale pink or red patches, technically called nevus simplex, often on the eyelids, bridge of the nose, or back of the neck, stork bite. They're just superficial capillaries and usually fade significantly over the first year or two. Again, reassurance is key.
Okay, last assessment point.
Mhm.
The umbilical cord. What are we checking?
We look at the cut end immediately after clamping to confirm there are 3 vessels, 2 smaller, thicker-walled arteries, and 1 larger, thinner-walled vein, AVA. Missing an artery can sometimes be linked to other anomalies.
And cord care.
The stump will start to dry and shrivel pretty quickly, usually within 24-48 hours. It typically falls off completely on its own within 7 to 10 days, maybe up to 2 weeks.
What's the parent teaching for cord care?
Keep it clean and dry. Fold the diaper down below the cord to expose it to air. No need for alcohol wipes anymore, based on current evidence. Just clean with water if it gets soiled with urine or stool. And the main thing is to watch for signs of infection.
Like what?
Redness spreading onto the skin around the base of the cord, any pus or foul-smelling discharge, or tenderness. If they see that, they need to call their healthcare provider. Okay, so before baby goes home, there are a few more crucial things. 3 mandatory screening tests are done on almost all newborns in developed countries.
Why mandatory?
Because they screen for serious conditions that might not show any symptoms at birth, but can cause severe problems if not detected and treated early. Early detection is everything.
Okay, what's the first screen?
The universal newborn screen, often called the metabolic screen. It used to be just the PKU test, but now it covers a whole panel.
How many conditions?
It varies slightly by region, but often over 30, even up to 50 rare genetic, metabolic, or endocrine disorders. Things like phenylketonuria, PKU, cystic fibrosis, congenital hypothyroidism, sickle cell disease.
How's it done? The heel poke.
Yeah, that little heel prick to get a few drops of blood onto a special filter paper card. Ideally done between 24 and 72 hours of age after feeding is started, because some tests rely on protein intake.
And it catches things early.
Yes. While each condition is rare, combined, they affect maybe 1 in 750 babies or so. Finding these early allows for immediate treatment like special diets or medications that can prevent severe disability or even death.
Okay, metabolic screen. What's number 2?
The newborn hearing screen. Hearing loss is actually one of the most common congenital conditions.
What's that?
Maybe 1 to 3 per 1,000 newborns have significant hearing loss. Early detection is vital for language development.
How is the screen done?
It's quick, non-invasive, usually done while the baby's asleep or quiet before discharge, uses little earphones or sensors. If a baby doesn't pass the initial screen,
They get retested.
yes. If they fail again, they need a full diagnostic hearing evaluation by an audiologist, ideally before 3 months of age. So intervention like hearing aids or therapy can start by 6 months if needed.
Okay. And the third screen?
The critical congenital heart disease, CCHD screen. This one uses pulse oximetry.
Pulse oximetry, measuring oxygen levels.
Exactly. CCHD includes several serious heart defects that might not cause an obvious murmur or cyanosis right away, but they cause low oxygen levels in the blood, hypoxemia.
When does this cone work?
A pulse oximeter sensor is placed on the baby's right hand and one foot, usually between 24 and 48 hours of age. We look at the oxygen saturation levels and compare the reading between the hand and foot.
What indicates a problem?
Low oxygen saturation, usually below 95%, or a significant difference, more than 3%, between the hand and foot readings is considered a failed screen and requires further investigation, usually an echocardiogram, to check the heart structure. This simple test catches babies who might otherwise go home with a life-threatening heart condition.
3 crucial screens: metabolic, hearing, CCHD. Now, what about mandatory preventative treatments? Vitamin K comes first. Why is this injection so important?
It is absolutely essential to prevent hemorrhagic disease of the newborn, HDNB, which used to be called vitamin K deficiency bleeding, VKDB.
Why are newborns deficient?
Two main reasons. One, vitamin K doesn't cross the placenta very well, so they're born with low stores. Two, and this is key, their gut is sterile at birth. They don't have the gut bacteria that normally synthesize vitamin K for us.
And vitamin K is needed for.
Blood clotting. Without enough vitamin K, their blood doesn't pass properly, putting them at high risk for spontaneous bleeding.
Bleeding where?
Anywhere. But the most devastating is bleeding into the brain intracranial hemorrhage, which can cause permanent brain damage or death. HDNB can occur in the first week, early classic, or even later, up to 6 months, late HDNB.
So the injection prevents this.
Yes. A single intramuscular injection of vitamin K shortly after birth, usually within the first 6 hours, provides immediate and effective protection against all forms of HDNB.
What about parents who are hesitant or ask for the oral version?
This requires careful, evidence-based counseling. Nurses need to explain that while parents can refuse, the injection is the proven standard of care worldwide. Oral vitamin K is available, but
It's not as good.
it's not recommended as equivalent. Absorption is unreliable, and it requires multiple follow-up doses over weeks. Crucially, studies show oral vitamin K is significantly less effective at preventing late HDNB, the type most associated with dangerous intracranial bleeding. Parents need to understand the increased risk they are accepting if they choose oral or refuse altogether.
That's a critical education point. What other routine prophylaxis might be given?
Depending on risk factors and location, the hepatitis B vaccine is often given in the hospital. And some areas, like Saskatchewan you mentioned, are now offering the new RSV immunization for infants during RSV season.
But routine childhood shots start later.
Right, the regular schedule typically kicks off at the 2-month checkup.
Okay, last section. This is more about the softer side, but just as important. Pain management and parent attachment. Do newborns feel pain?
Absolutely, yes. We know they experience pain. You see it in their high-pitched cry, their facial grimacing, changes in heart rate and breathing. We have a responsibility to manage their pain.
How do we manage it, especially for minor procedures like that heel poke?
We rely heavily on non-pharmacological methods, which are incredibly effective.
Like what?
Skin-to-skin contact is a powerful pain reliever. Breastfeeding during a procedure works wonders. Swaddling provides comfort and containment. Giving a few drops of sucrose solution on the tongue just before a poke can reduce the pain response. And non-nutritive sucking on a pacifier or finger. Nurses use these strategies routinely.
Great. And finally, fostering that parent-infant bond. Attachment. How do nurses support that?
It starts immediately by encouraging that early skin-to-skin contact, promoting rooming in so parents and baby stay together. But a big part is teaching parents how to understand their baby's cues.
You mentioned the newborn zones before resting, ready, rebooting. How does teaching that help?
It empowers parents to read their baby. The resting zone is sleep deep or light, needs protection. The ready zone is when the baby is quiet alert or active alert. This is the prime time for interaction, feeding, bonding. They're receptive.
And the rebooting zone.
That's when the baby is fussy, crying, or just seems overwhelmed, maybe turning away or shutting down. They're saying, I've had enough, or I need help to calm down.
So teaching parents to recognize the rebooting zone means?
It means they understand the baby isn't being bad or manipulative. They're just communicating a need.
Oh.
Maybe they need a break from stimulation. Maybe they need soothing. Maybe they're tired or hungry. Respecting that rebooting zone and responding appropriately, comforting them when they cry, is fundamental to building trust and secure attachment.
It prevents that cycle of overstimulation and parental frustration.
Exactly. Responsive caregiving is key. The nurse's role is really dual. Ensure physiological safety and empower the parents with the skills and confidence to nurture that relationship from day one.
Wow. Okay, that brings us pretty much to the end of this deep dive. We have covered a huge amount of territory today, from those immediate dramatic moments, the breathing triggers, the circulatory shunts slamming shut,
To telling kaput from cephalohematoma on the head.
right through to the essential newborn screens, the absolute necessity of vitamin K, and understanding those crucial behavioral zones for attachment.
I think the bottom line for anyone providing care or supporting new families is that dual role we just mentioned. You absolutely have to be vigilant for the subtle signs of deviation, the respiratory rate creeping up, the jaundice appearing too early. That clinical skill is vital.
But just as vital.
Is empowering parents with what's normal, normalizing the weight loss, explaining periodic breathing, Teaching them how to read their baby's cues, that knowledge reduces anxiety and builds confidence, which is probably the best safety tool you can give them for going home.
That makes perfect sense. So for our final provocative thought for you, our listeners, to chew on, we spent a lot of time on the amazing physiological leap into breathing air and circulating blood differently. But think about the behavioral adaptation. How might truly understanding and respecting the newborn's rebooting zone, their innate need to withdraw and self-regulate when overwhelmed, fundamentally shift how we, as caregivers or parents, approach soothing, interacting, and even just handling a newborn in those intense, exhausting first few weeks at home? It's not just about survival needs, but about recognizing their need for protection from our often overwhelming world.